بسم الله الرحمن الرحيم. هنبدأ الجلسة. First speaker دكتور أحمد إبراهيم. Recent updates for medulloblastoma treatment in children.
Good afternoon. It is my honor and pleasure to be here to give my presentation. My presentation today is about medulloblastoma standard therapy and recent advances in the era of molecular development. This is the outline of my presentation. First, I give a brief summary on medulloblastoma, where medulloblastoma is the most common malignant brain tumors, where the current standard treatment, as we all know, is maximum safe resection followed by craniospinal irradiation and maintenance chemotherapy. Medulloblastoma have improved survival rate along different times, and we reach cure rate about 70 to 8% now. However, survivor of medulloblastoma usually have different treatment-related morbidities like neurocognitive, neurological, and endocrinological sequelae, and the mortality is still significant. The well-known prognostic factors are age at presentation, extent of resection, metastatic status, histology, and molecular subtyping. This is are the well-known histological classification, including classic medulloblastoma, medulloblastoma with extensive nodularity, desmoplastic nodular medulloblastoma, and large cell oronoplastic medulloblastoma. Regarding the 2021 WHO CNS tumor classification, there were some changes which occurs in medulloblastoma embryonal tumors. Regarding the molecular subtyping, it is the same like 2016, including medulloblastoma Wnt subtype, sonic hedgehog, either P53 wild type or mutant, non-Wnt, non-sonic hedgehog. But the changes that medulloblastoma histologically is defined was mentioned like itself without mentioning the different histological subtype, this is the main change which occurs in medulloblastoma in the new WHO classification. Though histological subtype is still important till now, based on the new WHO classification, they mention that the histological subtype are no more important because the histological subtype are closely related to the molecular subtyping. For example, the desmoplastic nodular medulloblastoma are closely related or almost exclusively occur with sonic hedgehog medulloblastoma, and all Wnt tumors have a classic morphology, where most of the large cell oronoplastic tumor either to the sonic hedgehog or to group 3 and 4, which means that I don't have to mention histological subtype, and the molecular subtyping will be the main core of treatment in the next coming few years. This is the standard risk stratification where patients are classified into standard risk, high risk, depending on age, presence of residual disease, and the presence of metastatic status. And later on in my presentation, I will mention the new proposed classification of medulloblastoma, which I think will be within few years will be the standard of care for all patients with medullo. What are the challenges which we met in treatment of brain tumors? First, it is most of the brain tumors there is an utmost need to give radiation therapy, but we have to accept the presence of long-term sequelae of radiation therapy and incidence of secondary malignancies. And if I decided not to give radiation therapy, I have to pay the price by affection of the cure rate. Now I will mention the changes which occur in the standard of care based on the standard risk stratification. First, for the high-risk medulloblastoma, there was a trial which was published by COG, which is the COG 0332, where they divided patients with high-risk medulloblastoma into 4 stratum, examining the role of oral carboplatin as radiosynesthesia. They divided the patient to 4 stratum. First one was using vincristine as radiosynesthesia, a second using carboplatin with vincristine, a third are using vincristine as radiosynesthesia followed by citrotonic acid as maintenance, and the fourth one was vincristine and oral carbo with maintenance citrotonic acid. But in 2016, the 2 arms of including citrotonic acid were closed because they found there is no much of benefit from using citrotonic acid. There were 261 patients who were eligible for evaluation, and they found that the result didn't demonstrate a clear benefit of adding carboplatin as radiosynesthesia for the whole cohort. But specifically for patients with high risk group 3, there was 20% increase in the event-free survival and overall survival for patients with high risk group 3 using oral carboplatin, which means that it is very wise to use oral carboplatin as radiosynesthesia when I'm treating a patient with high risk group 3 medulloblastoma. Another trial, which is the St. Jude medulloblastoma 3, they were classifying the patient into average risk or high risk by the standard risk stratification, followed by craniospinal irradiation based on the risk, followed by 4 cycles of high-dose chemotherapy. They reported a 5-year progression-free survival of almost 86%, which is a very, very high survival rate for patients with high-risk medulloblastoma. Another very important trial, which was the phase 2 PNAT high-risk 5, they were trying to maximize the treatment approach for patients with medulloblastoma. They were giving 2 cycles of Ipsig carboplatin, followed by 2 cycles of high-dose Cytepa as a conditioning regimen, followed by CSI and the maintenance. So they were giving induction, consolidation by transplant, CSI, and maintenance temozolomide. And they reported progression-free survival of around 76%. But what was striking in this trial, which made me highlight this trial, is that all patients with group 4 medulloblastoma were metastatic, but at the same time their event-free survival were 100%, which means that intensification of treatment by using chemo, radiation, and transplant have nullified all the negative poor prognostic factor. This table shows a summary of most of the trial which was done for high-risk medulloblastoma patient, and in the third row is the heart approach, where we are applying some different approaches compared by the PNAT high-risk 5. They were giving 4 cycles of induction chemotherapy by high-dose methotrexate, followed by assessment. If the patient went in complete remission, he received CSI, followed by maintenance by vincristine CCNU, which is the standard maintenance. And if the patient didn't approach or didn't achieve the complete remission, he received 2 cycles of high-dose chemotherapy or CSI. So the PNAT high-risk 5 were giving all cases the high-dose chemotherapy, but the heart approach, they were giving chemotherapy, high-dose chemotherapy based on the response post-induction. So the ongoing SIOP high-risk medulloblastoma trial nowadays are classifying the patient or certifying the patient into 3 arms. Arm will give the heart approach, the other was the PNAT high-risk 5, and versus the conventional chemotherapy and the conventional radiation therapy. They did this because they want to compare different treatment strategies so they can conclude the best approach for patients with high-risk medulloblastoma. And it's very important to highlight that the high-risk infantile medulloblastoma patient have reported the best outcome with the COG 0334, which is the data, final data is not yet published, but they were giving 3 cycles of induction followed by tandem transplant, 3 times transplant, and they showed the best outcome for high-risk infantile medulloblastoma patients. Regarding the standard risk medulloblastoma, this is a very nice trial which was done by the COG. They made 2 randomizations. First one, they include about 550 patients. They were comparing between a posterior fossa radiotherapy versus the involved field radiotherapy just giving on the tumor bed. And the second randomization was comparing the patient who have 3 to 7 years and comparing between a low-dose craniospinal irradiation 18 gray craniospinal compared by 23 gray craniospinal. They concluded that the event-free survival of patients who have involved field radiotherapy and posterior fossa were almost the same. There was no big difference, but they found that the event-free survival for patients who received the low-dose craniospinal irradiation was 71% compared with 82% with the standard dose craniospinal irradiation. So they concluded that involved field radiotherapy is not inferior to the posterior fossa, but the low-dose craniospinal irradiation cannot substitute the standard dose craniospinal irradiation. But regarding molecular subtyping, they found that patients with sonic hedgehog medulloblastoma have a better outcome with involved field compared by the posterior fossa, and the low-dose craniospinal irradiation affected very much group 4 outcome compared by patients who received the standard dose craniospinal irradiation. And they found definitely that patients who received 23 craniospinal irradiation have more affection or decline in the IQ compared by the low-dose CSI. So they conclude that reducing the radiation post-volume in average risk medulloblastoma is a safe approach and does not compromise the survival, but reducing the CSI dose is not applied and is not applicable to decrease the dose from 23 to 18 gray. The SIOP 5 now is trying to, based on the result of the COG 0332, where they found the benefit from the carboplatin as radiosensitizer, they are now trying to use concurrent carboplatin as radiosensitizer, followed by 8 cycles of chemotherapy. This may improve the outcome for standard risk medulloblastoma patients. Based on that, carboplatin is more efficiently penetrate into the brain and have a longer half-life compared by the cisplatin. The second part of my presentation, I will talk on about the changes which occurs in therapy compared by or related to the molecular subtyping. This was the first consensus paper which was published in Acta Neuropathologica in 2012. It was the first consensus paper talking about the 4 types of medulloblastoma, which is the one sonic hedgehog, group 3 and group 4. And the conclusion for this paper was very important. They concluded 3 main conclusions. The first one, that the 4 subtypes are completely different regarding the demography, the clinical data, and the genetic background. Second, that the molecular subgroup remains the same all over the course of treatment, which means if I have a patient with sonic hedgehog at initial presentation and he relapsed, he will remain also sonic hedgehog. And if he's a group 3, he will remain group 3. The third one is that the molecular subgroup is the most important prognostic factor for patients with medulloblastoma. These are four subtypes of medulloblastoma, where winter represent 10% with 90% survival. Group 2 and 4 are almost the same, 30% with survival around 75%. And the group 3 is the least incidence, 25% with survival around 50%. Regarding the winter medulloblastoma, due to the excellent prognosis observed in patients with winter medulloblastoma, there are several ongoing trials trying to reduce both the craniospinal dose and the chemotherapy intensity, which was tried in 3 ongoing trials, which is the St. Jude medulloblastoma 12, SIOP-PNAT 5, and SNS 1422. Regarding the COG 1422, they are reducing the CCI dose from 23 to 18 gray without giving vincristine and radiosensitizer, and they're reducing the cycle from 9 to 7 cycles. So we reduce the numbers of cycles and reduce the dose of craniospinal irradiation. Regarding the SIOP-PNAT, which is secondary type, the low-risk arm where non-metastatic medulloblastoma with WNT are included. They are trying to give a CSI dose of 18 gray with post 54 gray to the primary tumor bed, and followed by a less number of cycles by giving just 6 cycles of maintenance chemotherapy, alternating between cisplatin, cisplatin vincristine, and 3 courses of cyclophosphamide vincristine. While the high-risk arm were the metastatic patient, although their patients are metastatic, but still they are giving a lower dose of CSI, 23 gray, with post to the cranial metastasis 45 gray, and total dose of spinal metastasis also 44 gray. There was a pilot study which was done by the COG trying to omit totally radiation therapy. They are trying to give just surgery followed by chemotherapy, but they found that this trial was closed early on because they found out of the 6 patients included, 2 of them developed spinal metastases. So they concluded that absence of radiation therapy or omission of radiation therapy is not sufficient for treatment of non-metastatic medulloblastoma when subtype. So I can reduce the dose, but I cannot omit totally radiotherapy. The third trial, which is the St. Jude medulloblastoma 12, they are classifying the patient into, as we see, which is the first time for the St. Jude to classify the patient according to molecular subtyping. They are divided into WNT and sonic hedgehog, into low risk and average and high risk. Where the low risk are WNT, gross total resection, non-metastatic, classic histology with no MEC amplification. Intermediate risk are WNT or sonic hedgehog with gross total resection or near total resection and no MEC amplification. Whereas high risk is metastatic patient with any other poor prognostic factor like no gross total resection or presence of c-MEC amplification. Regarding the non-WNT non-sonic hedgehog are divided also in average risk or intermediate and high risk based on molecular classification. Where the patient with WNT medulloblastoma with stratum W1, they are a patient with M0, gross total resection, classic histology, and monosomy 6 will give a much lower dose, which is 15 gray. So the St. Jude were giving down to 18 gray, but here St. Jude are given down to 15 gray, but the results are still pending. Regarding the sonic hedgehog medulloblastoma, it is well known that childhood sonic hedgehog medulloblastoma is associated with germline mutation of the P53 as part of Leigh-Fermini syndrome, with also association of amplification of the GLI2 and the MEC amplification, which are all considered as a poor prognostic factor in spite of high dose of craniospinal irradiation. So based on the previous data where they found that all patients with germline mutation of P53, sonic hedgehog, all of them died in spite of giving a higher dose craniospinal radiation and chemotherapy. So in the SIOP-PNAT 5, they tried to explore another approach, saying that so long as I don't have much of survival rate, so I don't have to induce more toxicity. So they decided to remove totally alkylating agents from the treatment and giving doxorubicin, high-dose methotrexate, intraventricular methotrexate, followed by maintenance of emaplastin, and giving focal radiation therapy if the patient is M0. But if I have a sonic hedgehog patient who have a germline but M positive, I am obliged to give craniospinal irradiation, but giving at a lower dose, which is 23 gray. But if the patient is P50 is somatic and he doesn't carry germline mutation, is giving the standard dose CSI 36 gray with post to the spinal and the cranial metastasis. So they decided to decrease the intensity of chemotherapy to avoid alkylating agent and trying to reduce the radiotherapy dose because they believe that there is no benefit from giving higher dose of CSI. So I had to try to avoid toxicity so long it doesn't affect the cure rate. Back to the COG 0334, which is the recent COG trial, they found that all patients with chronic hedgehog medullary, all of them were metastatic, but their survival was 100%, which again shows that intensification of treatment by using induction 3 cycles and 3 cycles of tandem transplant high-dose chemotherapy can nullify the negative prognostic factor being metastatic disease. Regarding targeted therapy like SMOSIN inhibitor Vismodegib, which have showed promising result in recurrent patient with adult medulloblastoma, now the St. Jude medulloblastoma are trying to incorporate Vismodegib as a maintenance treatment for 1 year after the end of therapy, based on the preliminary improving result caused by Vismodegib. But as all targeted therapy, usually the response is short time because due to the development of acquired resistance and point mutation, which resulted in 100-fold decrease in the drug binding. Regarding group 3 medulloblastoma, as we mentioned, concurrent administration of carboplatin during CSI has improved significantly survival by 20% for overall and event-free survival. And the St. Jude, based also on the phase 2 trial, which was carried in St. Jude by using gemcitabine as part of the treatment regimen for group 3 medulloblastoma, they found some efficacy. So now they are putting the pemetrexed and gemcitabine intermixed with the conventional therapy used in St. Jude medulloblastoma 12. And also COG 334 found that addition of high-dose methotrexate have improved the 5-year overall survival from 40% for the arm who didn't receive high-dose methotrexate compared by the arm to 80% for the arm who received high-dose methotrexate. So for group 3 medulloblastoma, adopting the COG approach by 3 cycles of induction chemotherapy and using high-dose methotrexate followed by 3 cycles of tandem transplant, I can improve the outcome of this very aggressive disease. Also, there are additional ongoing trials trying to use epigenetic targeted therapy like histone deacetylase inhibitor, which is called Virinostat. So the Pediatric Brain Tumor Consortium 26 have studied the addition of Virinostat as part of the intensive backbone chemotherapy for infant with group 3 medulloblastoma, and this have encouraged the COG to start a frontline COG trial using Virinostat as part of radiotherapy, concurrent with radiotherapy and for maintenance chemotherapy. So it started by the PBTC as in the pediatric brain tumor as a maintenance. Then now in the ongoing planned COG trial, they are trying to put it concurrently with additional therapy and also as a maintenance chemotherapy. Finally, for group 4 medulloblastoma, giving the superior outcome observed with group 4 medulloblastoma who have chromosome 11 loss. They are trying now in the COG trial, which is named 2031, they are trying to reduce the CSI dose also to 18 gray. And believing that group 4 and group 3 are sharing the same molecular landscape, there are now more encouragement to try using the drug which was used in group 3 like histone deacetylase Virinostat or gemcitabine to be also tried for group 4 medulloblastoma. But this is the most important slide in the presentation, that still patients with metastatic group 3 and sonic hedgehog with P53 mutation are considered a very high risk patient. Those patients till now, there is no standard of care of them, and they're usually considered as a very big hassle in their treatment and very poor outcome. So now they are trying to intensify treatment by any ways, by using high-dose chemotherapy, using maintenance therapy, intrathecal therapy, but still there usually is a concern that those patients are usually chemo-resistant and radio-resistant. So there is usually fear that I may intensify treatment and I get toxicity and with limited or no benefit. Finally, this is the proposed new risk stratification for non-infant childhood medulloblastoma, which I think will be the standard of care or the base of future trial as like St. Jude medulloblastoma 12, where they are classifying the patient into low risk, standard risk, and high risk, and very high risk. Where low risk are WENT patient and group 4 who are non-metastatic with chromosome 11 loss, standard are sonic hedgehog without MEK amplification, non-metastatic, group 3 no MEK amplification, non-metastatic, group 4 non-metastatic with no chromosome 11 loss, and the very high risk patient, which is extremely important, are the T53 mutation, whatever metastatic or not, and the metastatic group 3. So the very high risk group are metastatic group 3 and P53 positive mutant germline mutation sonic joke regardless of metastatic status. So, summary, medulloblastoma is no more a single disease. Not all patients of medulloblastoma should be treated by the same concept. Molecular subtyping should be the base of our treatment plan. The risk of therapy should be weighed against toxicity and the benefit of cure. Thank you. Perfect timing.
Thank you, Dr. Ahmed. Any questions?
Thank you very much. I have the pleasure and honor to present my colleague and my close friend, Professor Mohammed El-Beltagi, the head of the Neuro Surgery Department at 57357 and the Professor of Neurosurgery at the Qasr Al-Aini Faculty of Medicine. He's going to speak to us about the management of pediatric craniopharyngioma, a very important topic. Dr. Mohammed.
شكرا دكتور محمد ودكتورة ريم، مبروك على المؤتمر الناجح وأشكرك للدعوة الكريمة. I'm going to talk about the management of craniopharyngioma في ال children. يعني الموضوع هيبقى فيه surgery وأنا شايف معظم اللي قاعدين oncology، فهيبقى يعني في شوية عمليات ودم وكده. Pediatric craniopharyngioma is very challenging. ليه؟ Why؟ ايه الفرق بينها وبين الادلت؟ الكومبلكس بالانس بين الاوتكم والتيومر كنترول. يعني it's a benign tumor. To control tumor في the children for long life against the quality of life دي difficult. To remove the tumor totally you have a poor quality, ولا to remove partially you have a good quality. It's proximity to hypothalamus والoptic apparatus، حاجات مهمة ال child need them for their growth. ده الهرمونز ده make the tumor very challenging والmanagement بتاعه very challenging. In contrast to adult، طبعا الادلت craniopharyngioma البابيلاري تايب، احنا هنا الادامانتينوماتس تايب هي الكومنست، ودي بتبقى more solid and cystic وبتبقى طالعه من الراسكس cleft pouch وبتبقى attached and invading mostly الhypothalamus. الميوتيشن in beta catenin on the other hand the Wnt signaling في الادلت. We have done till now over 300 cases of adamantinomatous craniopharyngiomas. ابتدينا with 8 cases as a referral center, mostly in all over Egypt and outside in the Middle East. It's very challenging surgery. Most of the cases present with headache and increased intracranial tension and visual deterioration. Usually visual deterioration is not obvious in child, except if the mother is smart enough to recognize in early he's having poor school performance أو عنده بيقرب من التلفزيون قوي. You can discover the tumor early, rarely. Usually the tumors discovered lately وبتبقى large. 70% of the cases present with abnormal hormonal profile, mainly diabetes insipidus. The most common also is hypothyroidism. المانجمنت strategies is divided يا اما follow up، يعني نعمل surgery complete resection or near total resection and then we follow them up, or partial resection and radiotherapy اللي ما اختلفش عليها حد، او if it is completely cystic we just insert an omaya and then start interferon injection until the patient gets in maturity وبعدين decide surgery. We have done the follow-up cases for 110 patients. يعني follow-up تاني يعني total resection أو near total وما عملناش أي adjuvant therapy وسيبناهم for 110, given radiotherapy for 183 and the interferon injection only in 5 cases. This is a shift of protocol. لما ابتدينا with usually doing total or near total resection, we found there is different in the quality of life deterioration في ال quality of life في ال children's دول in the form of gross maturity وال poor school performance aggressiveness كلها hypothalamic مش visual. We shifted later to more إنه نبقى conservative يعني maximum safe resection and then giving radiation. This shows an improvement for the overall 5-year progression-free survival rate for the over 15 years as shown here. Again, the management protocol: maximum possible excision, adjuvant therapy for any residual in radiotherapy, أو conservative surgery and adjuvant therapy. ما بنقول conservative, it's not a synonym to subtotal excision. It's should be very individualized and tailored approach. يعني we could never say all cranios will be treated by surgery and follow up, أو all cranios will be treated by radiation أو partial resection. كل حالة is individualized حسب الحالة, البرزنتيشن, الage, السيستيك ولا solid. Talking about conservative surgery, we have to consider age, endocrine, visual assessment, radiology. Intraoperative assessment is the most important. There was some classifications to try to classify these craniopharyngiomas radiologically قبل العملية to define if it is attached to the hypothalamus, if it is compressing, if it is invading. And this grading accordingly ممكن pre-operatively you decide you are going to remove it total ولا partial. بس intraoperatively الوضع مختلف. يعني ممكن نقول ان this is just compressing الhypothalamus لكن intraoperatively تبقى invading الhypothalamus, and a trial of resection ends up in hypothalamic manifestation. You could never tell before the surgery. Where intraoperatively when you decide to remove parts even if it is just attached to the hypothalamus, دي بيبقى through pulling technique, يعني مفيش dissection. Then you will have hypothalamic manifestation because the hypothalamus usually does not like to be manipulated in the surgery, وإلا هيبقى very poor outcome. Gross total resection is usually the goal when it is safe and dissectable وfeasible. Subtotal, leaving intentionally the least possible residual on the hypothalamus when the lesion is seen invading it, وده بيبان جوه العملية باستخدام endoscope أو microscope magnification، أو زي ما قلنا الأماية for cystic just inserting it يا إما stereotactically يا endoscopically أو by open surgery also. بس الأماية is not a treatment. Again, the just delay of the treatment، يعني بنأخر بالانترفيرون لغاية لما الماتيوريتي والهرمونز تبقى preserved وبعدين نعمل surgery. Gross total و near total, we've done that in 91 patients. Subtotal resection means less than 1.5 centimeter left behind in 126 cases, and Omaya in 78 patients, either as an initial or plus the surgery, and no surgery at all for 3 patients with dense calcification. ده شكل intraoperative endoscopic. دي شكل السيست بتبقى this is the foramen of Monro. لما بنخش بالمنظار بيبقى أول حاجة شايفينها الفورامين of Monro السيست، نعمل لها puncture زي ما شفنا كده، بيطلع الكوليسترول content inside the ventricle. Then we do continuous irrigation and endoscopically insert الأماية under endoscopic magnification. This surgery is just a bare hole surgery، يعني هو خرم في السكال. It's a half an hour surgery ending up in complete evacuation of the cyst and inserting an أماية ونعرف الdiagnosis. This is in all cases that are presenting with cystic tumor زي هنا مفيش إلا very small solid part attached للكيازم. Then you can continue with interferon أو even radiotherapy. Conservative surgery, again, the concept is greatly aided with the use of this endoscopy. في نوعين من الاندوسكوبي، يا اما اندوسكوب زي اللي شفناها من شويه endoscopic insertion of أماية هنحطها بالمنظار ببير هول in a half an hour، او endoscopic assisted microsurgery which means ان احنا هنعمل microscopic surgery huge 6-hour surgery even 8 to remove the tumor, but we insert the endoscope during the surgery علشان نشوف ال underneath of the chiasm ونشوف ال attachment of the hypothalamus which is not usually obvious by the microscope، أو endoscopic endonasal transphenoid اللي هو زي ال pituitary surgery from the nose، ودي مش feasible في كل ال children، ليها criteria هقول عليها دلوقتي. endoscopic assisted microsurgery الفايدة منها زي ما قلت for the non-blind dissection، لأن usually الميكروسكوبيك surgery لوحديها فيها blind dissection وبنشد على الهايبوثالاموس وممكن end up in hypothalamic manifestation. The use of the endoscope together helps in non-blind dissection. وبيزود ال extent of resection وبرضه بنleave the least possible smallest residual و it's usually safe resection. ده is an addition not usually used by most of the surgeons to use both the microscope and the endoscope together during the surgery. This is what is new. For example ده حالة 9-year-old who presented by this short stature. ده شكل المicrosurgery. This is the frontal lobe. This is the temporal lobe. That's the optic chiasm. That optic nerve, right optic nerve, right carotid. ده الtumor. This is the third oculomotor nerve. ده how we do the microscopic surgery. You can imagine in the corridors are very narrow. You have the carotid, you have the right optic, the left optic. This is the chiasm, that's the lamina terminalis. وده ال third cranial nerve. يعني manipulation very narrow using the microscope عشان to get out all this huge tumor من الجزء ده. أو from these narrow corridors. It's usually hazardous أو يعني risky. Especially إن في perforators. الperforators دي بتسبلاي الكيازم for the blood supply بتاعها والhypothalamus. يعني injury of the perforators could be only enough إنها تعمل لنا complication. This is how we do the microsurgery. Usually إن شايفينه زي ما احنا شايفين كده الأوبتكس والكاروتيد بالماجنيفيكيشن بتاع الميكروسكوب. When we insert the endoscope زي هنا بقى through this narrow through these corridors you can see a higher magnification. كده تقدر نشوف ال small residual يعني حتة زي دي كلها كانت underneath the chiasm and is not obvious by the microscope. Inserting the endoscope magnification helps إن احنا remove safely الحتة دي من غير ما نinjure الكيازم. ده منظر الاندوسكوب لغاية جوه. This is the hypothalamus by the way and that's the basilar artery تحت. We go down لغاية البرين ستيم من التريونال أو من فوق which is ودي small residual attached هنا لل underneath of the chiasm وللhypothalamus which I left behind intentionally رغم إني شايفها عشان it is invading. الكلام ده عمره ما كان هيبان في الميكروسكوب. This is the post-operative. It looks like total resection بس في small residual اللي أنا وريته لكم ده مش باين في الأشعة. لو ما قلناش بعد كده يبقى anyone will see the image will decide in the total resection. These are another case which have extensions زي ما احنا شايفين رايحة ورا لغاية left temporal lobe نازلة عند البرين stem. All this going to the cerebellopontine angle وفيها calcification. الحاجات اللي زي دي أو التيومرز اللي زي دي could not be removed from single approach. اللي كان بيتعمل عادة إن بتتعمل 2 surgeries واحدة وبعدها بأسبوع واحدة تانية from behind. The use of the endoscope again ممكن نعملها من ناحية واحدة من فتحة واحدة زي الفتحة الأولانية. This is the left carotid artery وده left optic nerve. ده right optic وده الكيازم. Again نفس الطريقة dissecting و getting out what could be removed totally زي الحتة اللي طلعت ديت. وبعد كده we continue by the endoscope to get الحتة اللي ورا instead of doing 2 surgeries apart ب 2 weeks أو 1 week apart. هنحط المنظار تاني ونرجع ورا لغاية السي بي انجل. دول ال 7 8 cranial nerve. ده ال 6 cranial nerve. You can see من قدام رجعنا بالمنظار لغايه ورا عشان اشوف الكرينيال نيرفز. دي الانترنال اوديتوري ميتس. احنا داخلين من قدام عند الاي براو وراجع ورا بالمنظار لغايه السيربيلوبونتاين انجل to get all this only from one single approach. وده البوست اوبراتيف فولو اب. again لما بنسيب ريزيدوال بيبقى attached very small wall للهايبوثالاموس when decide if we're going to give radiation or not. في بقى الاندوسكوبيك اندونيزال سيرجري دي اللي هي through the nose. دي common في الادلت. in children it should be done بس في لغايه starting from 6 years old. لازم يبقى في pneumatized sinus. التيومر يبقى pre-chiasmatic cellular او small lesions. ما يبقاش ليه lateral extensions. يعني ليها كرايتيريا معينه. مش كل واحد يقول هيخش يشيل بالمنظار من المناخير craniopharyngioma in a child. That's not the common لأنها very risky. يعني this is one of the criteria. ده الهايبوثالاموس not attached pre-chiasmatic mostly cellular. This is how it looks like لما نخش بالمنظار من المناخير. This is the dura. بعد ما نفتح الديورا that's all through endoscopic endonasal surgery. الديورا that's the content. بعد كده بقى الدايسكشن كله بيبقى ماشي بلايند. ده عيب المنظار من المناخير ان هو we don't see the hypothalamus والكيازم الا lately بعد ما بنشيل التيومر، غير لما بنخش من فوق وبنشوف من الاول الاوبتيك كيازم والكاروتيد وكده. that's the tumor wall. بيبقى الدايسكشن ماشي smooth so long as we stick to the criteria اللي تنفع فيها الاندونيزال endoscopic surgery. It's easy if we stick again to this criteria. ده الفاينل بعد ما بيتشال اهو الاراكينويد انتكت، وورا بقى شفت الاوبتيك كيازم والكاروتيد. ادي الكيازم وادي الكاروتيد بعد ما التيومر اتشال which is not be possible لو كان invaded. ده البوست اب again نفس الفكرة، دولت حالات كلها يعني نفس الفكرة. after removal التيومر mostly بيبقى solid، بس أهم حاجة تاني sticking to the criteria we can get all the tumor from the nose leaving a small residue behind. sharply dissecting و cutting is very important عشان ما نشدش، يعني هو just traction gentle and sharply cutting، لأن لو شدينا في ورا الكاروتيد والأوبتيك نيرفز والperforators and it could be catastrophic. لو حصل bleeding from the nose then it will never stop. يعني دي بتبقى فيها intraoperative mortality. وفي الآخر الأراكينويد intact pulsating ووراه الأوبتيك نيرف والأوبتيك كيازم all the structures. نفس الفكرة تاني يعني نسكيب بقى الفيديوز. هي دي الكونكا النيزل، وده how we open the cella لغاية ما نخش جوه عند الديورا وبعدين نبتدي نريموف. This tumor was the same way calcified. وفي النهاية ده الديورال ريبير، لأن مشكلة الاندونيزال سيرجي هو الليك، بيحصل لهم CSF ليك، فلازم نحط باك زي اللي محطوطة ديت اللي هي تبلوك ال CSF ليك. This is one of the cases اللي هي عاملة extension فوق لغاية الهايبوثالاموس، بيتدخل لها يا إما ترانسكالوزال من هنا عشان نشيل الجزء الفوقاني، وبعدين تريونال من هنا نشيل اللي تحت. In such a case we just do it through terional approach، يعني single approach نقدر نشيل منه التيومر واقدر ادخل لغايه الثيرد فنتركل. ده فايده المنظار. الانترفيرون is used، بس هو المشكله ال availability of the interferon. I didn't find any response يعني that good من الانترفيرون زي ما الليترشر بيقول. عملنا ده البروتوكول of management using the interferon 12 injections over 4 weeks usually in de novo craniopharyngiomas يعني مش الريكارنت. ال 5-year progression free survival that's how it looks after radiation. والحالات الفولو اب طبعا اللي خدوا radiotherapy are much better. وده ال extent of resection في الفولو اب جروب compared to the radiotherapy group in gross total resection من غير radiation والgross total resection بالراديوثيرابي. البيتا كاتينين ده يعني احنا ابتدينا كنا فترة ان نشوف البيتا كاتينين aberration inside the tumor، وده was very helpful because we identified and when the aberration is more than 5%. This was done in 178 cases. لما يبقى أكتر من 5% then these tumors usually recur، لأن في craniopharyngiomas we remove them total and they still come back، وفي craniopharyngiomas we remove them partial and even without radiation they never come back. فلازم هيكون في مشكلة. We are studying this on both things. Recently doing mitochondrial research على الكرينيو solid and cystic part وعلى البيتا كاتينين، فلقينا ان معظم اللي still come back they have an aberration in their beta catenin over 5%. Then we decided giving radiation therapy even if it is totally excised after the total excision. وده البروتوكول of management which we already published اللي هو لو هي craniopharyngoma والبيشنت stable، لو completely calcified we go for radiation، لو هو cystic يا اما بنعمل ventricular عامل ventricle كبيره بنخش ببرهول واحد بس ونعمل الأماية، او نفتح ثرو سيرجري ونحط أماية وناخد بايوبسي. لو cystic lesion hugely cystic ممكن تتعمل stereotactic. لو هو mixed solid and cyst then we do open surgery using the endoscope. لو attached للhypothalamus او invading we end up in subtotal and near total. then radiation. لو gross total and safe و confirmed, then we do this and follow up. If the beta catenin above 5%, then we give radiation. So craniopharyngioma is highly challenging tumor, especially in pediatric age group. Very precise and wise decisions are always needed. The concept of conservative tailored surgery must be kept in mind. Multimodal management is very important. Psychological assessment, hormonal, كل الكلام ده. Management should be done in very specialized center and integrated multidisciplinary centers. Thank you.
Thank you very much, Professor Muhammad. Although I am not a surgeon, I learned a lot from this lecture. Any questions? Yes.
Thank you very much, Dr. Muhammad. As always, a very interesting lecture. And بضم صوتي للدكتور محمد. Very interesting videos as well. كان سؤالي هو عن استخدام الراديو سيرجري في الالجوريزم الحلو اللي هو اتحط في الاخر. يعني هل الراديو ثيرابي هنا سواء فراكشنيتد او راديو سيرجري، ولا كنت دايما بتستخدم فراكشنيتد؟ وطبعا دكتور محمد سعد يعني يشاركنا في الحوار.
هو احنا mainly most of the cases fractionated. We send 2 or 3 cases for gamma knife, but they did not do well. يعني 2 of them had an aneurysm. They later on aneurysm حصل فيها 2 عندهم aneurysm which is very يعني strange، بس they reported في literature انه حصل لان it's intensive على حته معينه، وهو already كل المكان زي ما انت شفتي very vascular، كلها vessels، والتيومر بيبقى متشال، فهو بيتاخد على جزء صغير. ده reported في حالتين، والحاله الثالثه جالها recurrence بسرعه and was not controlled.
انا سؤالي بسبب ان احنا يعني الكرينيوفارنجوما مش malignant tumor، وبالتالي ما تنطبقش عليه قوي القواعد بتاعه ال4 R's. فايه اللي يخليني افراكشنيت لو بعد عمليه يعني زي الدكتور محمد بلتاجي عملهم وفيها ريزيدوال؟
هو اللي قاله الدكتور محمد هو المشكله انها very high dose localized في small area. I believe ان احنا لو ادينا fractionated
ستيريوتاكتيك بس fractionated.
fractionated يعني احنا يعني ممكن بندي 5 fractions في الاريا دي، فمش هتبقى الدوز بير fraction is very high to cause the complication اللي موجوده.
يعني هو طبعا احنا بقالنا 20 يعني سنه في السنتر بنعمل الحالات دي. انا I will have to revise طبعا، اكيد كلام حضرتك مظبوط، بس we already have a publication عن الكرينيوفارنجوما in adult اكتر.
الفرق بين papillary وادامنتينوماتس in children. حتى لو عملنا ريفيو اوف ذا ليترشر هتلاقي انه معظمه يا اما ستيريوتاكتيك راديوسيرجري،
بس السن الصغير قوي بس الادوليسنس they do much better. يعني السن من اول 10 ل 18 سنه they do much better. طبعا كبير. هو اهم حاجه حضرتك قلتها التailored تريتمنت، لانه السيستيك غير الميكسد غير التوتالي سوليد. يعني كل واحده حتى ساعات لما تبص حضرتك على الMRI شكل التيومر نفسه هو اللي ممكن يديك فكره، لان ساعات السيست بيبقى طالع سوبراسيلر، ساعات بيبقى نازل تحت. فتailoring of the treatment is really important يعني. Thank you very much.
Thank you.
دكتور محمد، كان عندي سؤال لحضرتك. in case of recurrence الالجوريزم ده برضو يعني you adopt even in recurrent patient if you follow radiologically وشايف ان العيان asymptomatic but still there is some sort of increase, what do you do؟
هو already I cut this part من البرزنتيشن، كان في جزء طويل على ال treatment of recurrence، بس هو ده it's already published بالطريقة دي for the de novo craniopharyngiomas. When it recurs after radiation we go for re-surgery. يعني في حالات كتيرة كان موجودة في البرزنتيشن بس أنا شلتها، اللي هي لما رجعت احنا we don't have any option تاني لو خدت radiotherapy غير ان احنا بنعمل re-surgery. ساعات بتريكير in the form of cyst، بنعمل أماية then we can still do interferon، بس الاوتكم بتاعه مش حلو في الريكارنت. أو لو هي رجعت in the form of solid then we go for surgery when it compromises the vision. لأن بيبقى الفيجن اتأثر مع الراديشن مع الريكارنس بنخش نعمل ري سيرجري. فهي الريكارنس treatment after radiation is only surgery but it's very difficult.
بس in asymptomatic patient you keep following the patient until you need intervention.
Whenever it compromises الفيجن أو الهرمونز مش كل.
شكرا.
Thank you very much.
Thank you, Dr. Muhammad, for your comprehensive and engaging presentation. I would like to present Professor Muhammad Saad Zaghloul, Professor of Radiation Therapy at National Cancer Institute and the Head of Radiation Therapy Department at CCHE 57357, and the lecture will be about pediatric CNS tumor. تفضل.
Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank Dr. Arim for very, very good organization of this very important conference, which we will wait year after year. Also, I would like to thank our colleagues, the chairperson. We are going to speak about the pediatric radiation therapy in pediatric CNS tumors. In Children's Cancer Hospital, during the period of from 2007 till 2022, we have more than 5,000 patients of the CNS tumors. Most of these are the low-grade glioma, but still we have a high-grade glioma, mainly in the brainstem diffuse intrinsic pontine glioma. However, we have the embryonal tumors, more than 1,000 patients, and the ependyoma is around 369 patients. And we have other types of tumors. The medulloblastoma has been covered very well and by my colleague, Dr. Ahmed Ibrahim, and I will skip all these because he covered these very nicely. The risk factors that he also insisted on is the age and the diagnosis, the extent of the disease. A diagnosis means that there a metastasis or not, the extent of the residual tumors after surgical resection, the histological types, and lastly the genomic and metabolic aspects that he covered very intensely. The Chang classifications for the tumors is not working, but the M stage is the most important. The M1 is the microscopic tumors, cells found by CSF. The M2 is the infiltration or nodular seedling of the intracranial meninges. The M3 is the spinal subdural seedling, and M4 is the metastasis outside the cerebrospinal axis. With the risk classifications, we classified patients into average risk, which has those patients above 3 years old with no metastatic disease after total or near total resection. Near total means that there is the residual is not more than 1.5 centimeters. The high risk is the otherwise, and the standard risk we give the low dose of radiotherapy, craniospinal irradiation, with the posterior fossa irradiation as a boost, or recently we shifted to tumor bed with a dose of 32.4, adding up the total dose into 55.8 gray. This together with the chemosensitization, then followed by the adjuvant chemotherapy. The high risk, we give 36 craniospinal irradiation and the posterior fossa 19.8 gray. Again, with the boost of any residual and chemosensitization, then followed by the adjuvant chemotherapy. Nowadays, there is a trial that they making the boost as tumor bed, not the posterior fossa. But we are waiting for the results for this trial. To summarize, the treatment is surgery followed by radiotherapy with radiosensitizer, vincristine, maintenance, follow-up with the late side effects monitoring and treating these side effects. This is our standard risk medulloblastoma roadmap. As you can see, radiotherapy with the vincristine, then rest, then maintenance chemotherapy. The infant medulloblastoma has been covered very nicely by my colleague, Dr. Ahmad Al-Himali. Again, this is to sum up our protocol. The initial maximum safe surgical resection, followed by induction chemotherapy, then second look surgery if feasible, and excision of the tumor as maximum as we can. Then we give focal conformal radiation therapy. After that, we give the maintenance chemotherapy. This is the survival, 5 years overall survival for the 100 patients that we treated in the Children's Cancer Hospital, and these 5 years overall survival is 45.7%, and the event-free survival is 39%, which is although not that good, but it's still good, better than others. The craniospinal irradiation is the most complicated radiotherapy technique that you can ever see. It's, as you can see, we are using the supine craniospinal irradiation. It's better than the prone because most of these patients need anesthesia. As you can see in this picture, the anesthesia is safely offered for these patients, and the monitoring is coming all through the session without any interference. So the craniospinal irradiation, the complicated maneuver is the matching of fields, because the linear accelerator is maximally 40 by 40 centimeters, so patients are much more than that. So we have craniospinal match, and sometimes if we have a taller child, we get a spinospinal match. We have used this for a long time through the 2D with the many muadlat, where to rotate the head angle, and then in order to make it with the diversion of the spinal fields, and we left a gap according to the equation, and this is improved much by the IMRT and VMAT. By this, will be the job of the physicist. He calculated the dose, making the dose from the top of the head till the end of the craniospinal irradiation homogeneous. So in the left-hand side, you can find the 3D photon, and you can see that many of the organs of the baby or the child is receiving a dose of radiation. This decreased with the IMRT, and then decrease more with the VMAT or tomotherapy, but the best is by the proton. And by the way, our proton in the Children's Cancer Hospital reached the site last week. And we are going to install it, and we are expecting to treat our first patients after between 9 and 12 months from now. This has been shown by Dr. Ahmed before, but here this is the patients with the 3 to 7 years old were randomized between either to receive 18 gray and those with the standard dose of 23.4. This 18 gray was stopped because there is a much recurrences with this dose. So there is another randomization with the either posterior fossa or the tumor bed, and the tumor bed was giving the same results as the posterior fossa, but with much less cochlear dose and much less auditory affection. So we had the same randomization between tumor bed and the posterior fossa, and we reached the same results with the much better auditory function for patients receiving the tumor bed. This is the difference between the tumor bed and the posterior fossa. In conclusion, various radiotherapy treatment parameters have been implemented in the treatment outcome of children with medulloblastoma. The radiotherapy parameters include the radiotherapy volume, the dose, the duration, and the timing, which is very important to give within the timing and the duration prescribed. Current studies are looking at treatment modification, escalation or de-escalation of the dose, as shown by Dr. Ahmed Al-Himari. Next one is the ependymoma. Ependymoma is the most common in childhood, and it is the second most common childhood brain tumors, representing 10%, and it is 60% in the posterior fossa, 30% in the supratentorial, and 10% in the spinal cord. There is the pathology of the ependymoma is either grade 1 subependymal and myxopapillary ependymoma, which was lately the myxopapillary ependymoma were considered as grade 2. And grade 3, for the grade 1, which was excised completely, there is no role of radiotherapy, while there is a controversy about the grade 2, and we are studying now the effect of radiotherapy on the grade 2. For the grade 3, we must give radiotherapy as an adjuvant. This is the pictures of the CT of the ependymoma. This is the pictures MR and the posterior fossa. This is for the supratentorial ependymoma. So for the therapeutic strategy, surgery is the most important, and the extent of resection is of utmost important. Post-operative radiotherapy is for those either grade 3 or those with residual is extremely important, and those who has metastasis in the spinal cord, we need to give craniospinal irradiation. Chemotherapy, there is no role for chemotherapy except for under trials to decrease the volume in order to allow the surgeon to do maximum safe resection. Is there a prognostic effect of the site, infratentorial or supratentorial? There is a lot of publications about that. One of them saying it's the infratentorial is better than the supratentorial, while the other is saying the opposite. So more or less, but you can see here is none of these are significant. So it doesn't matter for the prognosis if it is supra or infra, but the resection is the most important. You can see here that those who have R0, complete resection, the 5-year event-free survival is 84%, while those who has the residual R1, the 5-year survival is 63. So that means that shows you the importance of the complete resection for the ependymoma. For the radiotherapy, the dose is very important, and the timing of the radiotherapy, timing to receive radiotherapy after resection, and timing of the overall treatment time of the radiotherapy regimen. So in summary, the prognostic factor is the extent of resection, the age of the patient, the grading of the tumor, and the molecular genetic and markers is still now under thorough investigation. Dose response relationship, the dose has to be more than 54 gray. It's better to be 59.4, I mean 60. Role of the hyperfractionation is not clear, and the duration of overall treatment time is very important. Radiotherapy of tumor site, the 3D conformal radiotherapy is the minimum to use, but it's better to use a higher VMAT or IMRT. Radiotherapy in children less than 3 or 5 years to give radiotherapy. I think if it is indicated, so we have to give radiation, and we have quite a good number of patients received radiotherapy below 3 years, and they are doing quite well. It's less than the older patients, but it is still well. If we go to the where is the relapse occur, we can find that it is more or less, it's 29 out of 30 in the local relapse. So the dose of radiotherapy is the important for such patient. This is to see the dose more than 54 or less than 54, it's statistically significant. So to shift to germinoma, either we give a germinoma or non-germ cell germinoma. For germinoma, we give total ventricular irradiation, then boost to the tumor bed. And dose is 24 for the whole ventricular and 21 for the boost, summing up to 45 gray. Non-germ cell tumors, it needs extensive chemotherapy, then followed by craniospinal irradiation 36 gray, followed by 18 to 19.8 gray as a boost. Prognosis is much worse, of course, than the germinoma. The choroid plexus tumors, we have the choroid plexus papilloma, and this is the surgical, if it is excised completely, which is the usual case. The follow-up for the atypical papilloma, if maximum safe resection was done, so for follow-up, while the subtotal resection, we need to give a local radiotherapy. While the choroid plexus carcinoma, we give maximum safe resection followed by chemotherapy, then craniospinal irradiation. However, this part is not agreed all through the centers, but most of the centers are using what we are using. For the craniopharyngioma, after the good lectures by Dr. Mohammed Al-Biltagi, I have to skip all this, but the treatment overview is a surgical resection plus or minus external beam radiotherapy, and the best is to have the safe resection, either maximum or less. Even the less resection, less than complete resection, and radiotherapy give the same results as the maximum safe resection and with less complication. The intracystic chemotherapy or interferon or even radiotherapy is the for the cystic lesion with the multiple aspiration is also can be used. Limited surgery with two slides. Limited surgery and radiation, as I just mentioned, is as good as the maximum safe resection with less complication. This is the outcome. So our goal for craniopharyngioma is a functional preservation and restoration of the function of the patients. Of course, because it's benign tumors, and the brain stem glioma, the brainstem glioma either focal or dorsally exophytic or cervicomedullary or diffuse intrinsic pontine glioma, DIPG, and the first three is the have a good results, good outcome, but the DIPG, which you can see here in this picture, they having a very dismal results with the median survival of 9 to 12 months. Here you can see the differences between the adults and pediatric low-grade glioma or the first three brainstem glioma compared to the DIPG in adults and the pediatric. We have this, we studied the low-grade, the focal brainstem glioma, and found that either the observation, giving chemotherapy or radiotherapy having the same results. So this is the results of the DIPG, not improved through the last 40 years. So we use the hypofractionation, giving randomized patient between hypofractionation, radiotherapy, and the conventional fractionation, 39 gray and 13 fraction compared to 60 gray, 54 gray and 30 fraction. And we got this non-inferior results of both. As you can see here, and the complication rate is nearly the same, and even is slightly less in the hypofractionation. That makes us make another randomization between two types of hypofractionation, 39 and 45 gray, compared to the conventional fractionation, and this the results was it's non-inferior to each other. So what we are using now is 39 gray and 13 fractions. And for conclusion, for the pediatric tumors, we are searching for the cost of treatment on the child because with the radiation we get a neurocognitive delay, not only with radiation but also with chemotherapy and surgery, and even the disease decrease the IQ. So the hearing loss is affected, especially in the medulloblastoma with irradiation of the cochlea and giving cisplatin. We may have seizures, we may have secondary malignancy, and the craniospinal irradiation may affect the renal functions, the pulmonary toxicity or cardiac toxicity. So we have to be very cautious in our treatment in order not to. Thank you very much for your attention.
شكرا جزيلا دكتور محمد. Very nice presentation as usual. Any questions from the audience? أنا I have two questions. واحد ليا عايز أعرفه فده خليه على جنب. وواحد and I would like to ask, sometimes مع craniospinal irradiation we face neutropenia, فبنضطر نعمل interruption.
We face what?
Neutropenia, count declines. بنضطر نعمل interruption.
Yes.
للirradiation. التايمينج allowed from your side as a radiotherapist للinterruption ده، وهل ان انا لو قلبت بدل ما هكمل الكرينيوسباينال I will proceed with the cranial and the post فوق so as to avoid further neutropenia? I would like a recommendation.
We usually do that. If we are confronted with the neutropenia, so immediately we shift it to the boost first. It's not first, even in the middle, and then continue after we end of the
التايم الويندو اللي بيخلي حضرتك تقول لا I need to revert this process.
I'm afraid that it's not more than 3 days.
تمام. طيب هو السؤال الثاني ليه انا I know ان 57357 هي المين سنتر اللي بيعمل توتال بادي irradiation بالنسبه لنا في الترانسبلانت.
Yes.
بس عايز اعرف ليه some centers يعني what is the main difference ان انا ادي craniospinal irradiation تمام او I will go for total body irradiation. يعني ليه centers can do craniospinal easily very easily and total body irradiation لا ما نعرفش نعمله. difference في ايه؟
Difference. The total body irradiation needs. There is many techniques to do total body
it's technical, not the device.
It is technique, yes, because no linear accelerator can give you total body irradiation by its own. زي ما بيدي البرين ولا بيدي اي حاجه. ليه؟ لان انا ماكسيمم بتاعي 40 by 40. ف 40 by 40 ازاي هدي توتال بودي irradiation؟ بنتحايل على الموضوع ده ان انا لو عندي بانكر كبير فبجيب العيان في اخر البانكر واديله البتاع فتغطي ال 40 تبقى 160 مثلا. ف اربع مرات 160 يعني 4 مرات قد ايه. فدي واحده. او ان انا ادي تكنيك بان انا موفينج التيبل هو اللي يموف، او حاجات كتيره قوي على جنبه، او الامبريو بوزيشن. a lot of technique.
I think برضه دكتور محمد ما ينفعش نعمل فيلد ماتشنج خالص، يعني حتى
المشكله كلها في الفيلد ماتش.
يعني انت ممكن تعمل فيلد ماتشنج في الكريني سباينال مش في التوتال بودي. لازم تديه اون بلوك.
ممكن بقى نعمل فيلد ماتش. ازاي؟ بنعملها بالفي مات.
كنت لسه هسأل
ماشي طبعا.
في مات ما هوش فيلد ماتشنج بالمعنى
ما هو علشان كده ده بنقدر نعمل فيه توتال بادي والسنترز الثانيه لا. ما هو لو في في مات
ما كنت هسأل
على الفي مات. بنعمله دلوقتي في مات بالتوتال بادي irradiation باي في مات. فبالتالي الجنكشن هنا بيبقى كونتريبيوشن من الابر ومن اللور، يعني اولموست ما فيش جنكشن، يعني هو بيتاخد كله على بعضه ما بيبقاش فيه بتاع. بس ده الفرق يعني. فلازم الاول يعني I think ان هو ال VMAT is the solution for this يعني.
شكرا دكتور محمد. and as we conclude السيشن دي